7, and it's our 20th ECO session this year, and it's our first ECO session looking at orthopedic emergencies. Today we have a panel of wonderful panelists. I know they are going to take us through, and by the time we finish with this session, I think we will be able to handle all the orthopedic emergencies. So we have the president, ECSU, we have head of accident and emergency, Mulago, we have Dr. Lubega, Kadia, orthopedic president, we have Dr. Ojara, orthopedic surgeon, Gulu. So I'm going to be giving them a chance. I'm going to give them time to introduce themselves in detail, to tell us more about themselves. And in the meantime, we have a quick test that is running online. So everybody is logged on onto the call. You are welcome. Feel free to fill in those questions. Those questions are to help us to know what are the things that we shouldn't miss during the session so that we can serve you better. But before we start, I will again thank Seed Global for hosting us, initiating this, bringing knowledge and skills to our door. We are learning, we are enjoying, we are getting knowledge and skills right in our places without moving and without paying for them. It's just a small fee of just putting data on your gadgets, and that's all, and you get the knowledge and you get the skills. And today's session is going to be conducted in a different way. We are going to have time to really have practicals right where we are. So please go ahead to fill in the quick test. And this time I'll start from my left. I'll start with Dr. Doreen. Please introduce yourself to the audience and tell us more about you.
Okay. Good afternoon, colleagues. Good afternoon to the team online. Thank you for joining the ECO session. My names are Doreen Okong, Alaleit. I am an emergency physician, also a seed educator at Makerere University with Seed Global Health. And I am the current president of the Emergency Care Society of Uganda. I love practicing emergency medicine, and I'm glad to be here.
We are so excited to have you, Dr. Doreen. We also have Dr. Lubega in the studio, so please you can go ahead and introduce yourself to the audience.
Okay, thank you very much. Good afternoon, everyone online present here with us. My name is Dr. Lubega. I am third year orthopedic surgery resident at the College of Health Sciences. We also serve as the chief president of the entire college. Good to be here.
They told me that you're also the head of captain.
Yes, I'm the football. I'm the team captain of the UMS Sports Club, Uganda Medical Association, and I invite all the doctors to join us this Sunday. We have corporate games.
Wow, we are so excited to have you, sir. Online, we have a team of two of our seniors on a call. I'll call in Dr. Okello to please introduce yourself to the audience. As Dr. Okello is sorting out the internet connectivity issues, let's have Dr. Ojara from Gulu introducing himself to the audience.
Yeah, thank you so much. Our panelists at Ministry of Health. Thank you so much, our viewers. My name's Ojara Moris. I am an orthopedic surgeon in Gulu Regional Referral Hospital. And for today's session, I will be answering your chat questions. Thank you very much. And I hope we shall have a very fruitful discussion. Thank you.
We are glad to have you, Dr. Ojara, into our chat. I know all the questions that people are and concerns that people are having are going to be handled very well. So I know people are still filling in the pre-test, and we have about 3 minutes to finish that session. At this time, I'll allow one or two participants, if you're there and you want to unmute and you have something burning that you feel like in this session today we shouldn't miss talking about or teaching about, please, you can put up your hand or unmute and go ahead to give us your comment or your question or your concern. Team audience. Anybody online? I can see wonderful people online. Anybody who wants to share something they have, they feel like we shouldn't miss. This being our first session, tackling orthopedic related cases and emergency. Yes, I know we've had many surgery, pediatrics, emergencies in general, but this is specific, also related. So if you have a burning, a concern, question that you feel we shouldn't miss on this session today, you can put up your hand or unmute and go ahead to give us. I'll allow 1 minute. If nobody does, then we shall continue. That would mean that people are open-minded to whatever is going to be given out. Okay, so I don't see anyone, anyone's hand up, and I'm not seeing anybody like unmuting. So we are straight going to start with our session today. And our timeline, our outline is going to be, we are going to have a case presentation given to us by Dr. Lubega, and then we'll have a general approach to a patient who has a case related to orthopedic emergency. Then we shall have emergency approach to transportation of a patient with orthopedic emergency. Then we'll have a wonderful skills session where we are going to demonstrate of how to handle a patient who has orthopedic emergency. So at this time, I will allow Dr. Lubega, please, to give us the case presentation. Wonderful case that he has experienced in the 3 years, the best he has ever experienced related to ortho.
Okay, thank you very much. I hope I'm loud and clear. Yes, once again, my name is Robert Lubega, SFIA 3, Department of Orthopedics in Makerere. It is not the best per se because we receive cases every day. Yeah, but I prepared this for this session. Yes, next. Yes, so the case we have today is a BF, a 56-year-old female with no known chronic illness who was brought in by police at the A&E in casualty Mulago, where she presented after 2 hours with history of bilateral neck pain associated with inability to bear weight on both lower limbs and with bleeding from a wound on the right leg following a road traffic accident after she fell off a motorcycle where she was a passenger, which had been knocked down by a passenger vehicle. We call them taxis, with impact on the right side and with no history of loss of consciousness or bleeding from ear and nose or throat. Yes, so when the patient presented to us, next, definitely we've all heard of the ATLS, our emergency specialists are here. every patient who presents to us at the A&E must go through the ATLS protocols, the primary survey and the secondary survey. Because if you don't identify any life-threatening illness, by the time we fix the fracture, the patient is gone. Yes. So yes, we went through our primary survey. We did our ALC spine. We examined the patient, had coherent speech, was able to talk to us, which meant that they had a patent airway. We examined the C-spine. There was no C-spine tenderness or any step-ups. Yes, which meant that we didn't have any C-spine injuries at that particular time. So we moved on to the B, which is the breathing. Patient still had no significant abnormality. Respiratory rate was 18 beats per minute, saturating at 97% on room air, at equal air entry with no added sounds. We proceeded to the circulation, which is the C. Patient had normal capillary refill of less than 2 seconds. Peripheries were warm. However, had bleeding from a laceration of about 4 by 2 centimeters on the anteromedial aspect of the distal side of the right leg. So the heart rate was, the pulse rate was 118 beats per minute. It was thin, thready and regular. The BP was 102/64. The pulse rate was, it was 118, sorry. And then when we had the heart sounds, 1 and 2 were normal, with no added sounds. So at that particular moment, we achieved hemostasis with pressure dressing using gauze and bandage. And we gave the patient 1 liter of normal saline over 1 hour. And when we examined the BP, the systolic had moved up from 102, about 112/76, and the heart rate was 96 from 118. It was from 118. Sorry. Okay. Then we, of course, at that particular point, we started to do like go cannulas and picked up samples for investigation. When we moved on to the D and E, so in the disability assessment, the patient was fully conscious. Glasgow Coma score was 15 out of 15. Pupils were normal, equal, and reactive to light. On exposure, auxiliary temperature was 36.8, and the patient at that particular time had a mildly soiled dressing. The pressure dressing was mildly soiled at that particular time over the third distal aspect of the right leg. And we also noted that the patient had a valgus deformity over that right leg and with a procavatum deformity in the left leg. Okay, so we moved on to our secondary survey after ensuring that we had finished our primary survey. When we examined the patient from head to toe, I was in a fair general condition and in pain. She was fully conscious, no dehydration, no pallor, no jaundice, no cyanosis, no edema or any lymphadenopathy. So we moved on to our musculoskeletal system exam because from our primary survey, that is where the injury was. So we focused on that system first. So we examined both the lower limbs and of course the upper limbs. Lower limbs first. And as earlier stated, we had a valgus deformity over the distal third of the right leg with a 4.2 centimeter laceration on the intermediate aspect of the right leg. And we also noted that there was tenderness over that same area, and with bone discontinuity, when we palpated over the tibial crest, there was a discontinuity over that distal third of the right tibia, and of course also the step over the fibula. With crepitus, we didn't assess the ankle range of motion because the patient was in pain. However, when we palpated the distal pulses, that is the dorsalis pedis pulse and the posterior tibial artery pulses were all normal. And also when we assessed our dermatomes our dermatomes from L1 down to S1 were all normal. And then we moved on to the left lower limb. The patient had a procavatum deformity, which was between the mid and distal third of the left leg with no visible wound. Had severe tenderness over that same area and with bone discontinuity still over the tibia with crepitus. We need to assess the range of motion because the patient was in pain and the distal vasculature was still intact. We went ahead to assess the other parts of the lower limbs, the knee joint, the thigh and the hip joint, and there were no obvious abnormalities. We also looked at the upper limbs because we know that usually when there is high energy trauma, we can have multiple other injuries involving the limbs and also other systems. So we moved on next to assess the cardiovascular, respiratory system, abdomen, and there were no significant findings. We also moved on next. We also assessed the ear, nose, and throat, CNS, as earlier mentioned, and everything was normal. So, yes, so we proceeded with our history using our sample mnemonic. And of course, the signs and symptoms, as earlier been alerted to, were those. Patient had no food or drug allergies. There was not on any chronic medication or any other drugs. Next. Yes, now our past medical, past surgical history were unremarkable. Family social. She was married to one man with 7 children, 5 boys and 2 girls. All were still alive with no familial history of DM or HTN or illness. Yes, our last meal and LNMP, she was postmenopausal, and her last meal was about 7 hours prior to admission. So the events have earlier been stated. Patient presented to us 2 hours, brought in by police with history of leg pain with inability to bear weight, with no loss of consciousness or bleeding from ear, nose, or throat. Yes, next. So our problem list was that patient had bilateral leg pain, they had inability to bear weight on both limbs, and they had bleeding. They had bleeding from a laceration on the anteromedial aspect of the right leg. So when we took off our samples, we asked for ordered for CBC. HB was 12.4, platelet count was 340, which were normal. RFTs, normal. LFTs, hepatitis B surface antigen, RCT, hepatitis C, PTI and R, these were done prior to surgery. They were all normal. And we ordered for plain X-rays of the bilateral tibia, because that's where the injury was. Okay, so those were our pre-op X-rays. And as you can see, we can see fracture lines in the distal third of the right tibia, and the left, and fibula. The distal tibia fracture, yes, was a transverse pattern, and also we have a transverse pattern in the left diaphysis, the left tibial diaphysis. The adequacy of the X-rays, we know very well that we need we need a joint above, joint below, and we also need at least 2 views, 2 limbs. We had adequate X-rays, but unfortunately, when I was checking my files, I think we had cut them off. Those X-rays you see below were the continuation. So we had adequate X-rays, and they enabled us have come up with the diagnosis and also plan for management. Okay, next. So our diagnosis, we had a multiple injured patient who had an open right tibia and fibular fracture, and AO classification 4 for the tibia, 2 for the diaphysis, A for a simple fracture pattern, and then A3 for a transverse fracture pattern. The fibula is a 4F according to AO, and 2 in the diaphysis. It was an A1 because it was a spiral fracture pattern in the fibula, And then we had a closed left tibia fracture, which was also A04 to A3 because it was a transverse diaphysio fracture. Okay, so our management, initial management in A and E, as stated, we had, of course, we achieved hemostasis. As earlier stated, we gave IV fluids, we gave analgesia, we gave antibiotics, third generation cephalosporin, ceftriaxone, and we also gave IMTT because she had not received TT booster over the last 5 years. And then we went ahead to do surgical debridement. And yes, we applied lateral long leg back slabs because of the principle application of POP. As you know, we need to mobilize the joint below and the joint above, which was the knee and the ankle joint. They will, the experts will take you through in the demonstration session. So when we were debriding, of course, we extended the wound edges and the wound, the diameter of the wound was about 8 to 4 centimeters to expose bone fragments and then wash them out. And that was a Gastillo 2. Because according to the Gastillo classification, as we know, we have Gastillo 1, 2, 3 classification of open fractures, where Gastillo 1, you have diameter of the laceration of less than 1 centimeter. You have usually a following very low energy, and we have yes, minimal contamination. And Gastillo 2, we usually have the diameter of the wound is about 1 to 10 centimeters. Usually high energy injuries, and you have some degree of contamination, and yes, you don't have any previous stripping or any evidence of vascular injury. So in Gastillo 3, divided into ABC, we have the diameter of the laceration is usually greater than 10 centimeters, and we have usually have greater than 10 centimeters. You have A, B, C. So in Gastillo 3A, you have adequate soft tissue cover. What does that mean? That you have a big laceration, but after you debride and you oppose the skin, it closes the wound. Okay, it's able. It closes. It's able to close to oppose. And then in 3B, you have in 3B, you have the skin is not able to oppose. It's great. Of course, the laceration of greater than 10 centimeters, and you usually have evidence of periosteal stripping. And then in 3C, you have evidence of vascular injury. So the Gastillo classification is important because it dictates how much debridement we do and how much fluids. In Gastillo 1, we use 3 liters of fluids. Preferably, you can use crystalloids, but in case crystalloids are not present, you can use water. Okay, and then for Gastillo 2, open fractures, you add 3 liters. So in Gastillo 2, we need to wash with a minimum of 6 liters, and then in Gastillo 3, you need to use a minimum of 9 liters of fluids. Okay, to wash out all this foreign material and also yes, most importantly, in open fractures, antibiotic initiation is very crucial within the first 2 hours. The experts will talk about this. So that is what we did in casualty. And then yes, definitively we 3 days later, after the soft tissue swelling reduced, we of course plan for definitive surgery, and we went in for open reduction, internal fixation, and we fixed the patient with intermediate nails bilaterally as per the what? as per the X-rays below for the right, because we had a short distal fragment, we used an expert nail which has multiple distal locking bolts. As you can see, of course, the expert will give us the details. So that is what we did for our patient. Thank you for listening.
Wow. Thank you so much, Dr. Lubega. I am here laughing. Wash with 9 liters. Does that make sense? Eh? Someone say that you wash till when it doesn't make sense to you while you're washing. Then you confirm that you've done some good job. Okay, so I've seen our audience has really increased. Thank you so much for logging on to our call today. And you can please continue to share the link to others so that they don't miss out on this wonderful session. We have some concerns. Some people have put out some things that we shouldn't miss in today's session. Someone talked about the tonic weight. He wants the panelists to tell us how much time should this tonic weight, if I apply a tonic weight, should stay on someone's limb. Someone wanted to know if I am in a center where there is no orthopedic surgeon, like what are those things I must do before I refer this patient, or like which better way I have to care for this patient before I refer them to a center where they have an orthopedic surgeon. You talked about a patient being multiply injured. Dr. Lubega, can you clarify on polytrauma versus multiple injured? Are they the same words, meaning the same thing, or there is a difference? And thank you so much for talking about the Gastillo. I think in brief, I think our audience got those. So can you talk about polytrauma versus multiple injured briefly before we go to our next session?
Okay. So usually, multiply injured patients are those that have more than one injury, but in the same system. Okay. Polytrauma patients, patients who have more than one injury in different systems. That is the basic understanding of those two terms. So you notice that this patient has a fracture of the right tibia fibula and a fracture of the right tibia fibula. I mean, left tibia fibula. So this is the same musculoskeletal system. And if the patient had a head injury with a fracture, then those would be polytrauma patients.
Thank you so much. Thank you so much for putting out that and clearly stated. So on our chat, we have Dr. Okello, who is our expert. He's the head of Accident and Emergency, Mulago National Referral Hospital. And he's our expert for the next, going to be leading us in our next item on our chat, and that is to give the general approach to the orthopedic patient. We all had this case, how this mother came, is a mother of 7, married, who was involved in a road traffic accident. And these are the patients that we encounter daily on a daily basis. And anybody can be a casualty, really, nobody can be spared. So this patient should be handled very well. If you miss out, the 7 children are going to remain with no mother. So we're going to welcome Dr. Okello to be taking us through the general approach. What should we do for this patient? Dr. Okello, you're welcome. Dr. Okello, I think you can go ahead to unmute. Maybe we can have a next item on the agenda.
Try calling him.
Okay, as we are assisting Dr. Okello, do we have any other concerns about this patient, this case scenario that has been shared to us? The team or our audience, team online, are there something that you want to know more about this case scenario or things that you want to share? I can have one or two people unmuting or putting up their hands and share out. Team online. I can see we have people from Kampala Hospital. We have teams from our regional referral hospitals. We have students, emergency students online. Anybody who wants to ask a question, this should be an interactive session. We want to hear from our audience. You want to hear from our audience?
Someone has raised their hand.
Okay. I can see someone putting up their hand. You can go ahead to unmute and ask your question. Can we have Mtambi Ibrahim?
There's a message there. There are messages online.
Mtambi Ibrahim, can you please unmute?
Good afternoon, everyone.
Good afternoon.
First of all, I would like to thank the organizers of this session. My question is about sprains and strains.
About what?
Sprains and strains. I still have a difficulty in differentiating between the two. The sprains and strains and how we can go about them. Because it's like they are the most abundant in our communities down here in health centers.
Okay, thank you so much for that great question. And it's going to be attended to. Can I have also Parker? Parker, can you also unmute and share your comment, your question?
Is that me, Gillian Park?
Yes.
Yes, hello. I'm actually, I'm talking to you from London. Good afternoon, good morning.
Yeah.
I've just, I enjoy these sessions very much. I've just sent a document to Gerald Niringe. I perhaps haven't pronounced that properly. He asked the question about tourniquets, and it's a useful document about position statement on tourniquets from the Royal Court of Surgeons. So perhaps he could put that into the chat for everyone to see it. Enjoying the session very much, and thank you so much. Thanks.
Thank you so much, Julia. Thank you so much for that great feedback. Again, this goes to Seed Global, Ministry of Health, to make the world so small. We are joined with colleagues all over the world for this session and sharing knowledge and skill where we are without moving, without paying for it. Thank you so much. So I think Dr. Okello is ready. And we will allow him to go ahead to lead us into the next session on the agenda.
Jimmy,
Okay,
presentation.
as,
Okello's presentation.
we are very sorry, Dr. Okello still has poor internet connectivity. When he's speaking, we can't really
But
pick
you
up.
can, you can
And the team
present
is
for him.
working so tirelessly to see that that is rectified. We still have more concerns and questions. People asked about what was the choice of analgesia while doing debridement, and they asked about the sprain and strain. Yes, I think Dr. Lubega should first clarify on that. And after that, we shall have Dr. Doreen as Dr. Okello still we electrify the internet connectivity issues. Dr. Lubega, what's the difference between a sprain and then a strain? Should I worry about it? What should I do? There are very many things that people put in the locally, the local medicine. Do you advise us to continue, go ahead? Please give us an idea about that.
Okay, so usually when we talk about a sprain in the layman, it's usually layman language. We mean that there is an injury or tear to the ligament. Okay, so ligaments usually those soft tissue that connect bone to bone. Remember that in primary, most of us were out there. And then a strain is usually a tear of a muscle or a tendon. Okay, that's in the simplest way. Yes, so
do you repair those ones also?
Yes, it depends, but it depends on the degree of the tears. So it's usually very important that usually minor tears that where you can still continue to walk on your own. Usually just give you painkillers, usually NSAIDs, things like that. And then maybe topical sprays, cold compresses, things like that, and it usually heals. Because usually ligaments, tendons usually heal by 6 weeks. They're healing. Okay. So if they're minor, but if they're big, and of course we have several structural ligaments like those in the knee. Okay, the anterior cruciate ligament, posterior cruciate ligaments, those big ligaments that hold your knee together. If those ones are torn, you're supposed to come see an arthroscopic surgeon to repair them arthroscopically. You understand?
So what should I
reconstruct, not repair? Yes. So what should you do is come see the doctor.
Okay, what I want to know, should I come like with my leg, my limb immobilized?
Yeah, so
With
naturally, usually, unless it's a fracture, as long as you're able to walk, you can walk and come. You can walk and come to us, because immobilization is usually for the severe grades, okay, where we can put you in splints and things like that, braces and things like that. But like I say, you need to come to us, we examine you, and yes, investigate you to be able, because what might seem minor to you might not be minor. Most of the time people get their knees kicked, they tear their cruciates, and they continue to play on those knees. And then before you know it, everything is in a mess. So you need to come see your orthopedic surgeon, and we shall be able to manage you adequately. And then the other thing, someone asked, what choice of antibiotics? I mean, what choice of painkiller?
Analgesia.
Yes, it's important to note that the first phase of bone healing, just like wound healing, is the inflammatory phase. Okay, where we have several cytokines released, to initiate the process of bone healing. So we do not encourage NSAIDs, non-steroidal anti-inflammatory drugs, in the first 2 weeks. Okay, because that's usually the phase of the inflammatory, the inflammatory stage of bone healing. So we usually prefer central acting analgesic that we all know, paracetamol. Then we can add an opioid. Okay, an opioid depending on severity, but if paracetamol does the magic, you do not add the opioid. You follow the analgesic ladder, but skipping NSAIDs in simple terms.
Oh, so that
Yes.
means ibuprofen, diclofenac, cyclofenac. That
Mm.
is so important.
Yes, dexketoprofen, the so-called ketes, those ones are usually out in the acute phase of fracture management. And most of the times, people are giving diclofenac because it's what is available. You understand?
Thank you so much. Thank you so much, Dr. Vega, for that clarity. So we are going to go straight ahead. I told you, audience, that today we are going to have a wonderful session, skill demonstration. We are going to learn skills right at our doorpost, in our houses, in our sitting rooms, in our rooms. So we are going to really give it much time. So at this time, we are going to have Dr. Doreen, our president, taking us through the emergency approach.
Give him the floor. He's on.
Oh, Dr. Okello is ready. Oh.
Let him unmute.
Dr. Okello, please can you go ahead to unmute?
It's like as if he's unmuted. No, continue.
Okay. Okay, Dr. Doreen, you can go please ahead to give us.
Hello? Hello?
Yes, Dr. Okello.
Are you hearing me now?
Yes, we can get you now, finally.
You can get me.
Yes.
Okay, thank you. Sorry
Yeah.
for all the inconvenience. All right. So, I'm Dr. Okello, as you all know, for those ones who have been with me. And my presentation is quite straightforward. And I want to go straight to the point. I start by introduction. Just give me a few minutes. I sort out a few things here in my computer. And then I come back to you. So many things went off when I was off. So everything got disorganized, but let me just sort it out in just 1 minute, I think I would have done. Yes, I'm there. So the most important thing to know, I'm just going to handle the activities that are involved within the emergency room. I'm not going to go into the detail of orthopedic care. And humerus, ulnar radius, basically they're all the same. They'll be catered for by this presentation, not that specific case that has been presented. And it's very important to know that in emergency with the history, getting a good history is very, very important. And then doing a thorough physical examination. Most of the time people miss at that level. And then when you have done your quick check, then the real approach to handle this patient starts with A, B, C, D, then E. That is how you are going to approach your patients on arrival at accident and emergency or emergency department, depends on where you are. Now, the A is, of course, is for the airway of this patient. Make sure that the airway of all the trauma patients are patent. Make sure they're breathing well. Make sure there is no serious active bleeding. And then you go ahead, you see where to do the drugs and examination. So for the bleeding, you must control your bleeding by doing pressure dressing most of the time. That's what is needed. Either you pack where the wound may be deep a bit, you pack and do pressure dressing. Don't apply a tourniquet dressing. A pressure dressing is simply properly fitting, snug fit, not so tight, not so loose. Control that bleeding. And then in some rare to do, especially for the superficial vein, you may to do it. You have to go ahead and spleen. We explained so many. You are going to control pain. You are going to control damage, because if you have fracture fragments that are freely moving, you are likely to cause injury to the vessels, to the nerves, or to the surrounding soft tissue. Use it. Use just make it the way it is. Flow in the area.
Dr. Okello, I think we have a challenge. We've lost you. Yeah.
Hello?
Yes.
My network is continuously going off, unfortunate.
We had lost you.
Are you hearing?
Now we
Yes,
can
it's
hear.
continuously going off.
Oh,
I don't know.
but now we can hear.
You again.
Now we can
Hello?
hear you. We can hear you now.
Yes, I'm here. Hello?
Yes, Dr. Okello. We can hear you now. I think you can go ahead. Okay. Hello,
Hello?
team. We are
Hello?
very sorry
Hello?
for challenge.
Continue to talk.
Hello?
Dr. Okello. Dr.
Yes,
Okello,
yeah.
we get you. We can hardly get you. Yes. So we are requesting that Dr. Doreen should proceed with sharing our part, our session, and maybe we share the slides with the audience. Because we can hardly get you, you're not clear because of the poor internet connectivity.
Yes, the connectivity. I'm hearing you, but it's continuously meeting me. I don't know where the music.
Okay. Maybe you can summarize in 1 or 2 minutes and hello. Okay, so
Hello?
yes, Dr. Okello.
Are you
Okay.
getting me now?
Okay, team audience, we are very sorry. We are going to We're going to have Dr. Okello's presentation in a different way. We are going to share the slides. That's a good thing. So at this time, we are going to allow Dr. Doreen to go ahead and share a presentation, and then after that, we shall have a demonstration because we have a lot of time for demonstration today.
Okay.
Doreen, you're welcome.
Thank you, Racheal. Thank you, colleagues online. I'm here to take you through the emergency approach of patients with orthopedic emergencies. I just want to put a disclaimer out there that fractures are not the only orthopedic emergencies that we have. We have fractures, we have compartment syndrome, we have neurovascular injuries, we have septic joints, and then we have the quad equina syndrome. So just for us to understand the emergency approach, for any emergency patient, the approach is the primary survey, which is the ABCDE approach. The purpose of the primary survey is to detect anything life-threatening. If there's an airway issue, if there's a breathing issue, a circulatory issue, a disability issue, and an issue in exposure. So most times that these patients come in, we might be distracted with the presence of a fracture, and yet this patient actually has an airway issue. So the very first thing that you want to identify, if you follow your ATLS guidelines, identify any life-threatening bleed. Ask yourself, do I see anything bleeding on this patient? Is the patient bleeding from a long bone? Is the patient bleeding probably due to a fracture pelvis? And then you arrest the bleeding. The next thing you want to identify if this patient has an airway issue. I'm not going to go into detail, but identify, you look, listen, and feel for any signs of air obstruction. Then you assess your breathing, you do your vital signs, check the respiratory rate. You also want to check and see if this patient has echo air entry. A patient can present with rib fractures. Patients with rib fractures are at risk of a pneumothorax. If they have a sucking chest wound, they could also present with a hemothorax. And these are things that you're going to identify with your clinical skills. So go back to basics, use your hands, use your ears, use your hands and identify if this patient is at risk of respiratory distress. In your circulation, the major concern you're worried about is circulatory collapse, hemorrhagic shock, but also neurogenic shock if your patient has had any injury to the spinal cord. We all know how to identify circulatory shock or a patient who is hemodynamically unstable. You're going to check the pulse, you're going to check the cup refill, you're also going to check the blood pressure. We now have eFast, and these are tools that we use at the bedside. A patient who comes in who is multiply injured, or a patient who has polytrauma, you need to start thinking about other injuries. And also if you look at the mechanism of injury. For example, the case that was presented, this patient had bilateral lower limb fractures. This patient could have been at risk of other injuries, other traumatic injuries. They could have had a hemoperitoneum. They could have had a bleed probably due to a liver laceration, or they could have a ruptured bladder, or they could have a bleed in the chest cavity. And now that we have POCUS, the POCUS is going to help us identify where this bleed is coming from, so that you can do during your assessment of your circulation. Obviously, for anything life-threatening, you stop and manage. If your patient needs fluids, you give fluids. If your patient needs blood, you give blood. We now have we now have TXA in our facilities, and we honor the use of TXA within the first 4 hours of presentation in the ED. And this TXA can help us reduce bleeding. We also now have an multidisciplinary approach to patients. We can now do damage control surgery. So if you have a patient coming in and they have a fracture femur within the first 1 to 2 hours, call in your colleagues from surgery and take this patient direct to the OR. So once you've assessed your circulation, I like to add circulation with pain control. Please, please put in your large bore cannulas and help this patient with analgesics. My colleague has talked about the types of analgesics to use. We can use opioids now. We can have paracetamol, and you combine it maybe with your morphine or your fentanyl. We can have use of ketamine in the analgesic dose. So the choice of analgesics is going to be patient dependent. You want to look at your patient holistically and identify, is this patient at risk of respiratory distress? Therefore, I want to use maybe my morphine. Is this patient probably at risk of secretions or probably might have laryngospasms? Then you might lay low on your ketamine for a bit. So choose an analgesic that's specific to your patient, but please use analgesics. In your disability, don't forget to assess for your GCS, don't forget to assess for pupillary size because you want to assess for any signs of TBI, and of course your blood sugar. Like I said, these orthopedic emergencies, these patients come in, they might be multiply injured, they could have a TBI, they could have other injuries that are missed in the ED. So do a thorough assessment of your ABCDE. In your exposure, expose the patient. And this is where you're going to identify where the fracture is. You want to identify the fractured bone. You want to identify if this fracture is open or it's closed. You want to identify any associated injuries. Is this patient at risk of neurovascular compromise? You want to check and see if this patient still has a pulse, if this patient still has motor or sensory function of the limb. Someone commented about the use of tourniquet. And if you're going to use a tourniquet, it's going to be limb or life. So you're going to make a choice that this patient is at risk. And if I do not stop this bleed, this patient is probably going to lose their life. The danger with a tourniquet is that we don't use it adequately. Most times people use the tourniquet in the wrong way. They will probably apply the tourniquet in the wrong place, and therefore it's not serving its purpose, but also the timing of the tourniquet. Remember that if you're applying a tourniquet, this patient is at risk because probably they're going to bleed out. But also if you apply this tourniquet for a very long time, which is more than 2 hours, you're actually compromising blood supply to this limb. This limb is going to become ischemic, necrotic, and it's going to die off. So you have to ask yourself the question of whether I'm dealing with limb or life for this patient. So application of the tourniquet has to be taken into consideration. I just want to touch base on a few of the orthopedic emergencies apart from fractures. Now, before we run away from fractures, there are certain life-threatening fractures. Yeah. We have fracture femur. We have fracture pelvis. We have hip fractures. We have multiple rib fractures. One, because of their vascular supply, but because of the anatomical location of these bones. If these bones are fractured, it puts the patient at risk of other injuries, which are also life-threatening. For fracture femur, you're going to disrupt the femoral artery, and we know that you can bleed out for almost close to 2 liters of blood from fracture femur. So it's a life-threatening fracture. If you have fracture pelvis, again, you're going to rupture the pelvic arteries, and it puts someone at risk of blood loss of high volumes. So you need to be very careful with these 2 fractures. These patients are at risk of hemorrhagic shock, and they can die within minutes as soon as they come to the ED. For the hip fractures, which usually occur in our older patients, they put this patient at risk of, they prevent ambulation, and therefore what happens is that they're at risk of pneumonia, thromboembolic disease, but also they're at risk of rhabdomyolysis. For rib fractures, these patients are at risk of pulmonary contusions and other related complications. My colleague has done a very good job of talking about open fractures and their management, and I'm not going to add anything else there apart from emphasizing irrigation, irrigation, irrigation. Very important. Open fractures puts a patient at risk of wound infection, especially the type 1, yes, type 3 and type 2, actually. And these infections, the patient can present even with osteomyelitis, or the patient can even present with gas gangrene. And don't forget tetanus as well. So if you have a patient who has open fractures, make sure you irrigate as much as possible. Make sure you start antibiotics as soon as possible and give your prophylactic tetanus. to talk about compartment syndrome. Compartment syndrome is a very serious life-threatening complication of the extremities. The common fracture sites are your fracture radius and your fracture tib fib. Rarely does it occur in fracture femur. But the causes, you could have crush injuries, you could have circumferential burns around these areas. Tourniquets are also another cause of compartment syndrome. But also a patient who has a hematoma can also cause compartment syndrome. How do you make a diagnosis of compartment syndrome? Now, there are the 5 Ps. Some people have 7 Ps of compartment syndrome. But just to take us through, we have pain that is beyond proportion of the injury. We have paralysis, we have pulselessness, we have the Ps, one P is pallor, the other one is paresthesias. So if you come across a patient, pattern of injury is probably fractured one of those compartments. They have a lot of pain. The area is swollen. The area is has no sensation. The area has no pulses. And you can see that this patient's pain is really beyond of what, the injury could have been. Then you have to start thinking of compartment syndrome. It's a tense compartment. The skin is really tight over that compartment area. And so you need to call in urgent assistance because this patient needs urgent fasciotomy to release the tension in this place. The pathophysiology really is, think about arterial damage, but also direct injury to that compartment causing edema. You have ischemia, and then you have reduced blood flow in this compartment, causing the painful presentation in the ED. Sometimes, unfortunately, because of poor monitoring of our patients that come in, they come in with a fracture, and then we put a very tight, maybe splint. We don't assess after putting this splint if there is still blood flow to the area, if the patient still has a sensation, if there is still even movement to this splint, you're going to cause compartment syndrome. So sometimes it is self-inflicted as health workers that we can bring about this compartment syndrome. And one of the biggest complications is you're going to put your patient at risk of rhabdomyolysis and eventually renal failure, which I won't go into details, but it's a cascade of events that can put your patient into ICU. The other complications are joint dislocations. Particularly, I want to talk about the shoulder dislocations, but also we have knee dislocations and hip dislocations, yes. So we've seen images, there's this talk about anterior versus posterior shoulder dislocation and that kind of thing. But your anterior shoulder dislocations will come more commonly. Posterior are a bit rare, unless maybe your patient has been maybe convulsing or electrocuted. They can do happen, but most times we're dealing with anterior shoulder dislocation. The patient will present definitely in pain. They'll probably give you a history of trauma or a fall, and you make your diagnosis based on imaging. For a posterior shoulder dislocation, you have something called a light bulb sign. If you go on YouTube, you'll find these images. But one of the complications for shoulder dislocation is, one, they can put the patient at risk of neurovascular damage, especially the nerves, okay? The other thing is that with the shoulder dislocation, it predisposes the patient now to a fracture, okay? And your patient is in a lot of pain. In terms of closed reduction of your shoulder dislocation, relaxation is key. Pain control is key. I will keep saying about pain because we don't manage pain properly. And also not for shoulder dislocations, but when you want to reduce fractures, you have at your hands and at your disposal medications that can help your patient achieve muscle relaxation. So all these are going to help you to reduce these fractures. Okay. Sorry, dislocations. So you can provide medications that will provide muscle relaxation, but also analgesia. There are different ways and different techniques to reduce a shoulder. I cannot say one is better than the other, but the principle is basically traction and counter traction of the shoulder. Probably we can try and demonstrate it after this, but that's the basic principle. It takes a certain skill and a certain practice, but once you identify how this shoulder has been, how the ball has been moved out of the socket, you're then going to apply traction and counter traction on your shoulder. Most times you're going to use a sheet. Some people tie a sheet over the shoulder, or maybe a sheet across the patient's chest, and you'll have one person pulling at the arm, another person is probably pushing the arm in an abducted position, and this will help the shoulder to go back in place. About the knee dislocations and hip dislocations, so this, the best approach is early identification and diagnosis. For hip dislocation, usually it occurs due to high energy trauma. So if someone has been involved in a motor crash accident, usually they will present with internal rotation. If it's posterior, if it's anterior, they'll present in external rotation. The most common complication is necrosis of the femoral head, but also you'll have sciatic injury, injury to your sciatic nerve. So you need to call in orthopedic to come in and support you on this. I want to talk briefly about septic arthritis. It's another orthopedic emergency. And usually it's monoarticular, which means it happens on one side. And usually it's bacterial. Your common organisms are your Staph aureus, your Streptococcus. And usually it could be due to direct trauma, or maybe it could be invasion, maybe from an abscess, or maybe it could be a distant site. Maybe a patient has sepsis, a patient is immunocompromised, and they end up with septic arthritis. Very common in the knee, but can also occur in the hip joint, in the wrist, in the elbow, and also in the shoulder. And early diagnosis is very important, but usually the patient will present with joint pain, swelling, warmth, erythema, decreased range of motion, fever. You do your labs, but you can also do a direct aspiration of the fluid in the joint. I take it for microscopy and culture, and use the direct, if you use a culture, you're going to identify the direct organisms, and this will help treat your patient and improve the outcomes of the patient. Quad equina syndrome. So the spinal cord is like, if those who have seen a horse or a donkey, the tail of a horse or donkey, there are those, I don't know what they're called, but those things that hang from the tail of a horse. So that's how, think about the spinal cord like that. You have nerve roots towards the posterior end of the spinal cord. So what happens is that in cases of trauma, or in cases of pressure or infection, you'll have this pressure sitting on the nerve roots of the spinal cord. The patient will then present with motor signs and sensory signs, for example, weakness, reduced deep tendon reflexes, sphincter disturbance, so urinary retention, fecal incontinence, and they could have pain radiating to the legs. You need to do a thorough sensory assessment, but it's an emergency which requires urgent investigation and decompression, because you need to reserve bladder and bowel function for this patient. Specifically, what I want to discuss now in regards to orthopedic emergencies is the principle of fracture management in the ED is reduction, immobilization, and rehabilitation of your patient. In terms of reduction, first of all, you want to identify where is this fracture. You want to identify what type of fracture this is. Is this patient going to benefit from closed reduction or open reduction? So most cases of our open fractures are going to benefit from open reduction. And you might need orthopedics to come in and support you and make that decision. But the purpose of reduction is, one, it's going to reduce pain. So pain relief, because as you reduce the fracture, you're also going to help immobilize this fracture. And therefore, you're going to reduce pain. But also, you're going to prevent secondary injury of this fracture. This bone is broken, and it could be compressing a blood vessel or a nerve, and therefore puts the patient at risk of neurovascular damage. So in the process of reduction and immobilization, you're actually trying to save this person's blood vessels and this person's nerves, okay? But also you're trying to improve the outcome of this patient. In terms of rehabilitation, it's not really an ED practice because usually rehabilitation is done out of the ED. So we'll probably just reduce and immobilize. And reduction is something that can be done not only by the orthopedic team, but it can be done by someone pre-hospital, you know, by the roadside. We've seen border cyclists actually reducing and immobilizing in all sorts of, in bushways in courts, but it actually works. They'll get sticks, they'll get boxes, they'll get any sort of rigid material and try and immobilize this fracture. They might not necessarily reduce it, but then they'll try to immobilize it because the teaching is, you know, get some sticks and, you know, just align the sticks on the limb and then tie it up with a cloth or something. That is the rudimentary way of trying to immobilize. But the principle behind it is, one, you want to reduce pain, but also you want to improve the outcome of that limb. You want to ensure that you don't cause any other secondary injury. The principles really for reduction and immobilization are, you want to reduce and immobilize a limb, a joint above and below the fracture, okay? The other thing is that as you're reducing and immobilizing, you want to ensure that you are cautious about your neurovascular bundle. You want to check the pulse. You want to check and see if this person still has any range of motion in the limb. You want to check for any hope you can hear me now. Can you hear me now? Yes, okay. We apologize for the technical disturbance. But I just want to recap. I believe I must have gone off on the principles of fracture management, which are reduction, immobilization, and rehabilitation. For the ED management, we want to focus mostly on reduction and immobilization. Like I said earlier, before you reduce, you want to identify where is this fracture? Is this patient going to benefit from closed reduction and open reduction? How are you going to do closed reduction? Again, you need analgesia. You need the right type of material if you're going to immobilize. So you need something rigid. We have POPs and now we have different types of POPs now on the market. We no longer have the old school heavy white plaster. We now have lights, the light kinds. I forgot their name. It's very light. My son had a wrist fracture, and I went on the market to look for the lightest POP that would enable him to write. But now we have different materials. And people are going to say, we don't have POP at our facilities. Well, you can use boxes. Yes, we can use boxes as an alternative to your POPs. I've talked about how pre-hospital people are using sticks, people are using boards. But remember that as you're doing this immobilization, you need to ensure that you do not do any more harm to this patient. So there should be padding. There should be some sort of cotton padding or a cloth padding, because you want to avoid secondary injury. So you make sure that you apply some cotton or some gauze. You want to ensure that if you're immobilizing, you immobilize a joint above and below the fracture. Someone is asking when the light POP is coming to Mulago. So the other thing is, as you immobilize, we've talked about compartment syndrome. As you immobilize, you want to ensure that you are reserving the neurovascular bundle. So you want to ensure that this limb can still feel. So you want to check for sensory function. So you're going to ask your patient, can you still feel, if I'm going to immobilize maybe fracture radius, I'm going to check for sensation before immobilization. So as you reduce, you want to reduce to ensure that the bone is not compromising any nerves, and confirm that the patient can still feel. As you reduce, you want to confirm that there is still blood flow, okay? So you're probably going to check for pallor, As you reduce, you want to confirm that the limbs still have motor, there's a motor reserve. So you're going to ask your patient, can you move the fingers, all right? But also you want to check the pulse. So you want to check your distal pulse, okay? And this you can check both on the upper limbs, but also on the lower limbs. As you immobilize, and you've immobilized, you've put your wonderful POP or your wonderful box or your wonderful sticks, you want to ensure that after you've immobilized, you have not caused compartment syndrome. So you want to ensure, can this person still move their fingers? Can they still feel? Is there still blood flow? What is the pulse like? Are the extremities warm? Those very basic things. So that you will make sure that you're reserving a limb for this patient, because if we put a very tight POP, you might put this patient at risk of compartment syndrome, okay? And therefore they could even have lost their limb, but also you're putting them at risk of rhabdo or renal failure. So be very cautious as health workers as we are immobilizing these fractures. Again, I will emphasize pain management. Please help our patients and put them out of pain. These fractures are very painful, and some of us are reducing in a very rudimentary way. We are just providing traction and counter traction without caring about what we are doing, without giving any sort of analgesia or procedure sedation to our patients. And we are causing a lot of discomfort to the patients. So please prioritize pain management to these patients, and don't forget your ABCDE. My colleague has talked about how sometimes the fracture can mislead you. But friends, I ask you, make sure you go through your primary survey, because you will have a fracture femur, but your patient has airway obstruction. You'll have a fracture femur, but your patient is in hemorrhagic shock, okay? And your hemorrhagic shock is going to kill your patient faster than that broken bone. So I think that's it from me. It's such a big topic, but I feel I've tried to summarize it as best as I can.
Wow, wow. Oh, I feel like clapping.
Clap.
I think we can clap for Dr. Doreen. Can the audience hear me? Thank you so much, Dr. Doreen, again, our President, Emergency Care Society Uganda, for that wonderful presentation. I think you've tackled almost like everything that people have been asking about. We have James Peter had asked about compartment syndrome and wanted a pathophysiology. I think it's sorted out now. You talked about pain. Just to echo, they told me that we have an analgesia called Vaboken and Silica in Uganda. We reduce fractures. Hey, please, it's okay. Using our words, but I think maybe one time we'll have a session where we'll look at pain management, maybe control pain in EDO, in the hospital, in emergency setting. Because I think pain is a big thing. I talked about, someone had talked about which drugs to give when I'm reducing this fracture. Maybe something that you didn't talk about. Someone also asked which best antibiotics or which drugs should I give post-reduction, fracture reduction, or dislocation. Then someone also wanted to know, yes, you talked about the knee, the shoulder common, but what about the TMJ? TMJ dislocation. Many patients come to the ED when they cannot really close their mouth, they are in pain. What is the easier way to reduce them? Yeah, maybe we missed some question. Some Nigerian was asking, do we use Ottawa rules? Maybe this goes to Dr. Lubega. Ottawa rules in our setting. And then someone asked that you talked about that the still classification, but what about the Weber classification? What's the difference? It's important for us to know. Maybe you can, Dr. Lubega, you can talk briefly about that, then Dr. Doreen, and we shall have the skills section now. I'm excited.
Okay, thank you.
Briefly.
Yes, so briefly, Weber classification is usually classification we use for ankle fractures, where we have Weber A, Weber B, and Weber C. Weber A fractures are usually fractures of the lateral malleolar, of the lateral malleolar, so distal where we have the fracture line below the level of the syndesmosis, and then Weber B at the level of the syndesmosis, and then Weber C above the syndesmosis. So this one usually help us. This classification help us in management of ankle fractures. The other thing I wanted to emphasize is compartment syndrome. That the single most important P is pain. By the time you have all the other P's coming in, the limb is already ischemic. So remember this: compartment syndrome, pain on passive flexion.
Yeah, thank you. Okay. Thank you so much, Dr. Lubega. Dr. Doreen, I think now we can have the simulation. I can't wait to see us reducing fractures, dislocation, these shoulders, the belt. We want to see now how to go about this patient. I think the audience is waiting.
Okay, can you hear me? So we have.
Confirm whether you can hear Dr. Doreen.
Okay, so we have this patient right here. I will start off. Someone asking about pelvic fractures and I'll start off with a pelvic binder. So first of all, how to examine the pelvis and how to assess that you actually have a pelvic fracture. Because these fractures are very life-threatening, you will not have the luxury to rush this patient to the X-ray to confirm that there is a pelvic fracture in place. So the most ideal and basic way is basically you want to do something called a spring test. And for a pelvic fracture, you want to assess any signs of instability in your pelvis. So all you want to do is just press on the pelvis, kind of a motion like as if you're doing a spring, all right? And you press into the pelvis. And if you, first of all, any instability, any pain, anything that feels discomfortable on the patient, think of it as a pelvic fracture. You don't want to do this maybe more than once or twice, because if you have an open book fracture of the pelvis, the more times you keep assessing it, you're probably going to make it worse for the patient. Ideally, we have pelvic slings, and this is the ideal, and I know we don't have this at our facilities. This is a fancy pelvic sling, okay? But you can use a bed sheet to mobilize this fracture. What you want to do is identify the bony prominences, and these signify the greater trochanter areas, and that is where you're going to place your pelvic binder. Now, this is not a one-man job. This is a two-man job. It's a team effort. We can get a bed sheet here. So I'm going to use the bed sheet because it's more applicable in our setting. So basically, what you want to do is you want to be able to roll this bed sheet, okay? So you roll as well. So remember, you're given your analgesia, okay, for your patient, okay? So what you want to do, because of our nature as Africans, some people have a bigger backside area. And so what you want to do is rudimentary measure, okay, how much material you're going to need, okay? So one, identify your bony prominence, and you want to put it slightly below the gluteal area, all right? So probably this is going to be enough for the patient. Remember, this is the pelvis, it's not the waist, okay? So the upper border is at the greater trochanter area, and the lower border is just slightly below the gluteal area, all right? So what you want to do is, it's a two-man job. I would have someone else on the other end of the patient. And what you want to do is you're going to slide this. The best approach is slide it right below the knees, all right? Once you have rolled it to the other end, you're going to slightly pull up the piece of cloth until you've reached your upper border of your greater trochanter, all right? And then you'll have someone else on the other end and you on this other end. So if you can stretch, okay. So think of it as a tourniquet, okay? So you're going to try and use as much energy as you can. So as he pulls, I also pull. Do not let go of the pressure, hold. The patient should not fall, okay? And you continue this movement without releasing the pressure from your pelvic binder. I want to applaud certain regional referral hospitals. I believe some time back, we got a patient, I think it was from, I can't remember if it was Mbale or Jinja, and they brought a patient with a pelvic binder like this. So I want to applaud the regional referral hospitals because they're actually making use of the materials that they have. So until probably your cloth has been, used up, and then you could choose to tuck it in to the patient. So one piece goes there, another piece goes there. I've seen people tie this with a rubber band. I've seen other people tie this with a pen or a clamp to just secure it in place. Now, remember, this is now has taken the role of a tourniquet, all right? The role of a tourniquet, remember we said it's limb or life. Once you have this in place, remember now you're obstructing blood flow, all right? The rule of applying a tourniquet is you don't want to have a tourniquet in place for more than 2 hours. If you're in a position whereby the damage control surgery for this patient, whether it's on the pelvis or maybe you have a tourniquet to obscure bleeding from your femur or your tib fib, after 2 hours, you want to be able to release. So for example, if you had a tourniquet on your lower limb, and this limb has a likelihood that can be saved, You want to release that tourniquet, allow blood flow for a bit, and then tighten that tourniquet. Because once you keep this tourniquet in place for more than 2 hours, you're going to obscure blood flow to a point that you're going to get gangrene for this patient, all right? So once you have put your pelvic binder in place, you want, of course, damage control surgery for this patient. You want to ensure that your patient is not in shock. Remember your ABCDEs, your TXA, your blood. You're going to call the orthopedic team to intervene for this patient. So the next skill, yes?
I have a question.
Yes.
Why are you emphasizing the bony prominences and not up here in the waist, like some people do?
Because if you look at the anatomy, in the West, we have organs that sit within the pelvic area, all right? We have the bladder, okay? We have the uterus in women, okay? And so actually the pelvis is, I don't know how to anatomically describe it, but the pelvis is not up at the waist, all right? The pelvis is a little bit lower. If I'm going to have a fracture on the pelvis, okay, it's going to be around the bony prominence of the pelvis, all right, and not at the actual waist. At the waist, I have organs that I could actually cause more damage to. So imagine a tourniquet this tight on someone's bladder, or a tourniquet this tight on someone's uterus, all right? So we're actually not doing any benefit to the patient, all right? So now let's move to our splints. So there are these fancy splints. Some of our facilities, we have them. These are what we call some splints, all right? But like I said, we can improvise with sticks, with boxes, with blocks of wood or something, but ensure that there is padding done for your patient. So imagine you get something as rigid as a stick and you're putting it against someone's arm. You're going to cause muscular injury without putting some sort of padding, all right? So Racheal is going to be my model here. So if Racheal has a fracture radius, all right, I have confirmed that there is fracture radius. So clinically, we also have to go back to our clinical skills. We don't need to wait for an X-ray to confirm a fracture, right? So clinically, you're going to confirm, one, that there is deformity, that there is swelling, that there is discontinuity of the joint, of the bone, sorry. You even could actually palpate and actually feel any crepitus. But of course, the limb is tender. The pattern of injury could point you towards a fracture. So the excuse of we don't have an X-ray at our facility is just an excuse, okay? Use your clinical skills and use your hands, all right? Palpate the limb. Palpate for any tenderness. Look at the limb. Is there any deformity, all right? Palpate over the muscle and identify, can you actually palpate any crepitus, all right? I remember we told you that immobilization is one form of pain relief for your patients. We want to immobilize the joint above and below the joint, all right? So for every immobilization tool you decide to use, okay, make sure that it's the right size because it has to cover the joint above and the joint below, all right? So what you want to do is you want to ensure that there's padding on the rigid structure that you have. Here we have a SAM splint, which is nice because it's flexible and it can be bent in any way. Immobilize the joint above, immobilize the joint below the fracture, all right? And what you want to do with a crepe bandage is probably strap it round, okay? And then you ensure that it's kept restricted to allow to reduce range of motion. Remember we said before immobilization, I am going to now check for my pulse. Do I have my pulse? It's a pulse. Can you feel my hand? Yes. Can you move your fingers? Yes. Then I will immobilize. If I check and there's no pulse, there's no sensation, there's no movement, then you're going to attempt to reduce. What does that mean? It means that you're going to manipulate this fracture in such a way so that you're going to allow blood flow, but also reduce, maybe this bone is pushing against a nerve. So you want to attempt reduction and manipulate it in such a way using traction and counter traction so that you want to save this limb, right? So once you've confirmed that there is a pulse, there is sensation, there is movement, then you can go ahead to immobilize with your crepe bandage or whatever you have at your facility. After you have immobilized, go back and confirm, is there a pulse? Can you feel? Can you move your fingers? But even just look at the color of the hand, okay? Is it red, all right? Can I confirm that there's actual blood flow? Is it warm, all right? And there you're sure that you have allowed this limb to have life, right? Unfortunately, we don't have enough splints for the lower limb, but basically the principle is the same. You want to confirm with your dorsalis pedis if there is a pulse, but you can also check your popliteal area, okay, if there is a pulse. Same thing, sensation, ask your patient to move the toes. And of course, remember that you have to get a splint that's going to be the right size for your patient, depending on where the fracture is, right? I know there are questions about use of back slabs. My colleague here probably will comment about back slabs. Windows, I've seen patients being brought and they've done a POP and then they've cut out a window where this is a closed fracture, but they've left a window. So I want my colleague maybe to comment about that. But really the principle is the same. I see a neck collar here. So this is a rigid neck collar. Most of us don't have these in our facilities. And most of us actually make do with what we have. We have normal saline bottles. I've seen people even use blocks of wood. I've seen cardboard boxes being used. And the principle is, again, if you're concerned about any injury or any fracture to your cervical spine, you want to ensure that you put a neck collar in place. So it's quite difficult to manipulate with this dummy here. But again, it's a two-man job because you need to ensure that there's someone at the head of the bed immobilizing the cervical spine for you. And then you slide this onto your patient and then you lock it in place. Again, depending on what materials you have, I've seen facilities that have made their own neck collars and kept them. You know, I've seen, I think Mbara does that. Yeah, they right? Yes, they have boxes. They've improvised. So it's also an excuse that you don't have these. So make do with what you have. I think that's it for now. Yeah. Okay, dislocation. So I'm going to ask my colleague to come and we demonstrate shoulder dislocation. So for your shoulder dislocation, like I said, there are so many techniques you can use, but you want to provide traction and counter traction, okay? So I will abduct. So if you have a patient who you suspect has a shoulder dislocation, oh, maybe they can.
And our patient sit.
So how do you suspect shoulder dislocation? The patient comes in complaining of pain in the shoulder. One of the complications of shoulder dislocation is that they reoccur. So most likely, it's not the first time it has happened, almost the second time it has happened, okay? And if you examine this shoulder, you'll find that the ball is out of place from the socket anyway. if dislocated. Your X-ray is going to assist you to make a definitive diagnosis. But most times you actually don't even need the X-ray. You can do it bedside clinically to make the diagnosis of shoulder dislocation. So my colleague here is going to apply. So you can get a sheet and he's going to apply traction. Counter traction, yes. You come this side, you do this side, I do here. I don't know if you can see. You have to. Can you do counter traction from that side? Okay, yes, yeah. So, okay, so what you do is traction, counter traction, it's basically two opposite forces, all right? So you pull, I pull on this side while he pulls on the other side, okay? And as he's pulling, most likely he'll have to pull while trying to manipulate the shoulder back in place. And it comes with experience because you feel the shoulder, the pop, and the shoulder goes back into place. But it's very immediate. Again, if you make sure that you have a muscle relaxant and the right analgesic, it's going to be very good. But the key, again, it can only happen if your patient is relaxed. I think that's it for the skills, right? Yeah.
Thank you so much, Dr. Doreen. Thank you so much, Dr. Lubega. Actually, the audience is requesting if we could record these videos and we upload them, it will be good. And I think that is the team behind the screen working to see that that is being done. Again, I thank so much our expert. Thank you so much. It has been a wonderful session. So at this time, I'm going to allow team audience, team online to ask. I believe most of the questions have been answered. Dr. Ojara has been answering most of them, but I will allow one or two people. If there is anything still that is pending, you can use 1 or 2 minutes to air them out.
Online though. Is Dr. Okello still online?
And so we have even the director in the hospital, regional referral hospital. We are glad to be joined by.
The rest of the questions,
Dr. Ojara, if possible, you can unmute and respond to the rest of question when the team can hear.
When to use back straps or when to use complete casts.
Yeah.
Dr. Ojara, there was a question that Dr. Doreen asked, like the orthopedic team to give an overview of back slabs versus complete
Yeah,
cast.
Thank you very much for Mr. Marik who asked that question. Yeah, by definition, splints are anything, actually anything that you can use to immobilize a fracture or any other part of the body. But in the case of a fracture, or in our setups, you can have pre-made materials, like you see the use of the pelvic binders. Those are all under splints. The use of POP back slabs. So you ask that if the use of sticks, cardboards, and so on, which may look to be dirty. I think that we do not discourage, because at the time where accident happens, that might be the only thing available for you to help to immobilize that part. Therefore, you must use it safely. And use of spleen must be done safely. And safety there means you must make sure that the spleens are padded, the limb are padded, especially areas which are bony prominences or pressure prone areas must be properly padded with cotton or any other. Even if you have clothes, you can first pile some clothes and then you put your spleen so that you avoid complications associated with spleen use. Therefore, you can use that. If you have something which is very dirty, obviously, and you are immobilizing an open fracture, don't use it because you will again introduce infection on the wounds. But however, under miscellaneous type of spleens, you have all this. You can use wooden, a piece of wood on the way. You can use cardboard, you can use anything, even metals can be used. However, spleens, there are different types. Someone also asked about antibiotic use. In an open fracture, you encourage that antibiotics, especially broad spectrum antibiotics, which is given prophylactically. It should be given as immediately as possible. So as soon as you encounter the patient and you are able to get antibiotics, please give it as early as possible. That is about the use of antibiotics. And what type of antibiotics? Normally you use a broad spectrum antibiotics. Thank you very much. Any other questions that will come, I think we shall be responding as they come. Thank you very much. Back to you, the moderator.
Dr. Deb, before you stop your submission, someone had asked about the cast, putting cast vis-a-vis back slab and then putting cast and then we create an area or what they call a window. Do you have?
Yeah, thank you very much. Thank you very much. The cast or POP, actually all those are under spleens and they can be used. Whether you're using a slab or you're using a cast depends. When you have an open fracture and you have got a wound, therefore it is not a good idea that you cover the wound with a cast, a full cast. So the practice is usually you put a slab, either a back slab or a ventral slab. So when you put a full cast in an open fracture and you do not trust that this patient may obey your instructions, for example, elevation of that limb, if it is the upper limb or radius ulnar fracture, then the hand must be elevated, or if it is a tibia fibula or a distal femur fracture and you're using POP, splitting it means in most cases we call it bivalving. You must cut that circular cast that you have put in a longitudinal from the beginning, from around the toes up to the thigh where the cast has stopped. And then you open it so that you have room for swelling. Because this is a person who has just gotten injured and therefore the inflammatory processes are still ongoing. So if you still again add on a tight cast, therefore that can easily even predispose this patient to a compartment syndrome. That is why this cast is bivalve or splitted. Once you split, please, you put crepe bandage around it so that it can hold it in place. That allows room for expansion when there is either bleeding or you have edema coming in. But we always advise that this limb must be elevated. The use of windows, what we call windows, someone is saying you cut some holes. When you have an open fracture and you feel the need for continual dressing, you can do your debridement thorough debridement. After doing thorough debridement, and maybe in most cases, like here, most patients cannot afford orthopedic implant for primary fixation. So what you do is you have to put a slab, or you put a full cast. And once you put a full cast, you cut a large window around where there is that wound. And that normally helps us to dress this wound time and again on the wood. But never forget limb elevation to prevent compartment syndrome. Thank you.
Thank you so much, Dr. Ojara, for that clarification. I think all our questions have been really answered. Again, thank you so much, our panelists. It has really been a great pleasure. So at this time, we have a post-test running through. So please, team audience, you can go ahead to fill in. But we have someone, I can see someone's hand is up. Yeah, I can see Tambi, your hand is up. I'll give you 1 minute to unmute and air out your content. Meanwhile, we're filling our post test. Tambi, are you there? Tambi? Okay, I will assume that was a previous and we will go ahead with our post test. I want to thank so much APO, Association for Private Practice Ambulance, for giving us the equipment that we've used in today's demonstration, today's skill station. Thank you so much, Team APO. Again, I'll thank so much Seed Global for putting up this, giving us knowledge, coordinating the experts, coordinating the equipment and everything. But above it all, we thank Ministry of Health for allowing us to have this continuing session for us to learn and get skills. I think at this time, we can have 1 word of remarks from each of the panelists that are in the studio.
Okay, Virginia starts. Yes, thank you, viewers and everyone who was the audience for being present with us. I hope you've learned a thing or two. Just to emphasize compartment syndrome, pain. The other thing I forgot to talk about, open fractures can also present with compartment syndrome. So do not assume that someone has an open fracture tibia, they cannot get compartment syndrome. Lastly, do not put complete casts in acute fractures. Okay? Do not. Like Dr. Ojara said, either back slabs or if you put a complete cast, you have to split it because edema is going to set in in the inflammatory phase. Okay, edema will set in, swelling will happen. If you have a complete cast, there's going to be a buildup of pressure in those compartments. You're going to kill that limb. Thank you.
I want to thank the online team, for logging in. Learning is a continuous process. But also improves you as an individual. As an emergency physician, my bread and butter is the ABCD, and I'll keep singing that song. So please do your primary survey. Your primary survey helps you identify life-threatening conditions. Go back to your basics, your clinical skills, identify if your patient is at risk of air obstruction, is at risk of respiratory distress, is at risk of circulatory compromise, if your patient has any neurological deficits, and then again in exposure. Because if we cannot identify these life-threatening conditions, our patients are going to have a poor outcome. So thank you to Seed Global, thank you to Ministry of Health, and thank you to the presenters and my colleagues here.
Thank you so much, Dr. Doreen. So at this time, we'll allow the online team to please put on your videos. We are going to have a group photo to record this session 72, since we started to have this session. So please, you can put on your videos and we take a photo. Thank you. I can see some. I can see some opportunity. Please go ahead to put on your video and we take a photo. We have team from Kampala Hospital, team from our regional referral hospital. We have residents, we have students, we have individual people online. Please switch on your videos and we take a photo. I can see Isaac. Oh. I can see people, yeah, we can see you now. We can see you. Thank you so much. Thank you so much, online team.
Bye.
Andrew, I can see Zia. Yeah. Chelsea Serranico, Collins Waigolo. I can see Dr. Darlington, many people. Thank you so much, online team. Thank you. Again, thank you so much. Thank you, and thank you so much. The team that is in the studio, our experts, and the team behind the scene. This session is ended.
Yep.
And don't forget to log on to the next session, that is a week after next week. It's going to be about urinary related emergencies, in particular acute urinary retention. Okay, bye team. Thank you.
Thank you.
Hey, thanks everyone.
Thanks, you guys are good at keeping time.
Uh,
It's exactly.
very important. It's